Hello, everyone, and welcome to the final lecture of our semester. We're going to close out the COPD lecture today, and that will be it as far as Block 4 is concerned. So, last time we were talking about COPD and all the changes that occur to the pulmonary system, and one thing that does get altered during or in those with COPD is our compliance or the relationship between the pressure and volume of the lung. And so the relationship between pressure and volume is similar to the compliance curves of the blood vessels. And in order to calculate compliance, you have a change in volume. In this case, it's going to be a change in air or lung volume over a change in pressure. And that's how you get the slope of this curve. So down below here, you could see this where on this y-axis, this would be where our residual volume is. And then as we inhale and going from residual volume to a max inhale or total lung capacity, you can see that this relationship, this compliance curve, is not exactly linear. And so as we exhale the same thing, a relationship from that total lung capacity to that residual volume, you have a difference depending on what stage of the breathing cycle you are in compliance. And so intrapleural pressures are referenced to atmospheric pressure, meaning the differences there. So it becomes negative as the chest wall expands. And so as we talked about in earlier lectures, if you lessen pressure, if you increase the volume of the lungs, the pressure inside drops. And so you have a high compliance at normal range of intrapleural pressures, which is around -5 to -10 centimeters of water. But the lung is always going to have some air in it due to airway closure. And so that's why at the end of the exhale, you always have that residual volume left over. But with COPD, it becomes a little bit more difficult to move this air due to more air getting trapped, and it may result in hysteresis or the additional energy needed to inhale. Because since that excess air is trapped within the person's lungs, it's going to require more out of the respiratory muscles to move additional air in. And so in those with COPD, compliance is increased. A normal compliance is around 0.2 liters per centimeter water, while in those with COPD, it gets increased. So that's the main takeaway here as far as COPD is concerned and lung compliance. And the reason why that compliance is increased is because the normal architecture is destroyed with emphysema or COPD. There is less elastic recoil. The lung's going to hold on to more air, more volume of air, and that's why we see that increase in compliance. Again, that's volume over pressure. And then we also have, in extreme cases, fibrosis of the lungs, which actually would decrease lung compliance. But again, you have to sort of go patient by patient and depending on what stage they are to really look at the differences that occur. But overall, in those with COPD, you're going to see that increase in compliance because of more of that trapped air. And so the reduced elastic recoil and increased compliance of the lung will increase lung volume. So your total lung capacity and your functional residual capacity, the amount of air left over after a normal exhale, both of these values increase. Again, more air getting trapped within the lungs. And so we talked about the ventilation to perfusion ratio in earlier lectures. And so it's not only the difference in blood flow that causes a change in this ratio, it's also due to the fact that there is different levels of ventilation inside our lungs. And so it's partially due to the weight of the lung and the way it's structured. We have high compliance at low intrapleural pressures, and then low expanding pressure is going to equal a low resting volume. And so at these lower lung volumes, it's easier to take air in, right? So when you first inhale, that's going to be, when you get a lot of air, a lot of volume into the lungs. And then as the lungs fill up with more and more air, that percentage that you're actually taking in decreases. And so there are differences again when it comes to the parts of the lung. You're going to have the lower zone with a higher ventilation. So you're going to get more ventilation, more airflow coming in originally than the upper lung. And then, as we discussed with differences in hydrostatic pressure, so when you're in the supine position, the ventilation between the upper, middle, and lower zones gets a little bit more even, but there are differences between posterior lungs, so the backside of your lungs, versus the anterior lung. So again, not a crucial point as far as this lecture is concerned, but just realizing that there are differences when it comes to ventilation in your lungs depending on which section you are talking about. And so, these differences in, the ventilation become a lot more apparent in those with COPD. So you get that loss of elastic recoil, and then you're going to have an increased chance of compression at the lungs at higher lung volumes, and this is going to lead to reduction in gas exchange. So the fact that you have more of this air trapped inside of those with COPD means, again, it becomes stale, that less air is going to be able to exchange carbon dioxide and going to be able to exchange oxygen. And what's that going to result in? Well, negatively as far as blood gases are concerned. What we are going to see in those with COPD, since we can't get as much air in that takes part of that gas exchange, well, then we're going to have negative consequences for our blood oxygen levels and then our blood carbon dioxide levels. And so normally we would hope to see a arterial blood oxygen content of really around, it says here 85, but that should be closer to 100 mmHg. And then when you look at someone with COPD, the arterial blood oxygen is decreased. And so this is called hypoxia, which we know is a very negative thing. As far as carbon dioxide is concerned, we see that normally we would predict a blood carbon dioxide levels of around 40 mmHg, and since we cannot exhale as much air out, those levels are going to increase. And then along with that, we see more acidic blood, a drop in pH for those with COPD. So the fact that this air gets trapped in those with COPD, in the lungs with those with COPD, has very negative consequences as far as the chemical composition of our arterial blood is concerned. And so, again, it's not only differences in ventilation throughout the lung, but perfusion as well. And so normally we'd want that ratio of 1:1 of ventilation to perfusion to maintain arterial blood gases. And what COPD is going to result in is a reduced arterial oxygen and partial pressure, and then an increased carbon dioxide partial pressure. So physicians are going to prescribe certain medications in order to help those with COPD live a better quality of life. And the actions of those medications are to reduce the airway resistance and to increase the airflow in and out of the lungs. And by doing this, these medications are going to help the individual or the patient get out more air, so enhance emptying of the lungs, and then decrease the hyperinflation and the labored breathing that comes along with that. So a major treatment for those with COPD is going to be a bronchodilator. So these are going to dilate the air pathways of our pulmonary system, and you have two classes of it: anticholinergics and sympathomimetics. And so, if you remember, these are referring to both of our autonomic nervous system subclasses, the parasympathetic, which the receptors are acetylcholine receptors, whether it be muscarinic or nicotinic. And then the sympathetic nervous system, we're going to have beta 2 receptors in the lungs. And so, as far as airflow is concerned, when sympathetic nervous activity increases, when norepinephrine or epinephrine binds to beta 2 receptors within the lungs, this is going to dilate air pathways. So, by reducing the parasympathetic nervous activity in the lungs, and by increasing the sympathetic nervous activity in the lungs, we're going to get a dilation of those air pathways. And that's going to reduce resistance and increase air flow. So many of those with COPD will be put on a bronchodilator. And so, again, hypoxia is apparent in those with COPD. And so, in order to try to increase blood gases, to increase the partial pressure of oxygen within our blood, you have to breathe deeper. We talked about in the past few lectures how a greater alveolar ventilation will lead to a greater diffusion of oxygen into the blood. And so hypoxia is a very negative thing and can have horrible consequences as far as our physiology is concerned. But one way when COPD gets severe, in order to combat hypoxia, is to have oxygen therapy. So individuals will actually be given an oxygen tank that is typically hooked up to their nose, and this will give the person supplemental oxygen. And so when the person's O2 saturation gets below 88%, this is when they'll be administered oxygen therapy. And by doing this, it can improve their exercise tolerance. And by improving their exercise tolerance, they can partially, improve their lung health and their strength of their respiratory muscles to help them with their condition. And so how does oxygen therapy work? It reduces the ventilatory drive. So since we are supplying the lungs with that oxygen, it won't require the respiratory muscles to work as hard at rest. Because again, in those with COPD, those muscles have to work harder in order to overcome the hyperinflation. So with oxygen therapy, you get less likelihood of fatigue of those respiratory muscles. And so, overall, this is going to just reduce hyperinflation and then reduce the difficult or laborious breathing. So again, this is typically for more extreme cases, but oxygen therapy can really help those with COPD not have to have such laborious or difficult breathing. And so a major outcome of COPD is that because of all the changes that are occurring within our pulmonary system, the tolerance for exercise in those with COPD goes down. And so that sort of makes the condition worse because those respiratory muscles aren't getting stronger, and then that's going to have negative consequences as far as lung health is concerned. So as early as possible, we want to prescribe exercise for those with COPD so the condition doesn't worsen. And so you want to make sure that when you are prescribing exercise to those with COPD, that you find that sort of Goldilocks zone. Too little exercise, you're not going to get the adaptations that you are looking for in order to improve your pulmonary health. Too much exercise can also have negative consequences as well. I'm skeptic to say physiologically that too much exercise is going to be negative, but however, if you do pour on the intensity and if you give the person too much, you are running the risk of an episode happening because again, their physiology is not like normal physiology. So if you push someone too hard with COPD, it could have negative consequences. And also if you push someone too hard just mentally too, they may be turned off to exercise, and then that's going to make the condition worse because now they're going to develop the behaviors of, oh, no, I don't want to do that, that's too hard. So you want to find, again, that balance that's going to allow the person to continue to work out and allow them to get a little bit healthier. When you are prescribing exercise, make sure that you're looking for signs and symptoms. The talk test, again, is a great way to make sure that the person can handle the intensity of exercise. And we're going to divide our exercise prescription based on whether they have a mild COPD condition or more moderate to severe COPD condition. So we'll just go through some general guidelines for exercise prescription for those with COPD. There is really no optimal dose. Again, the more active you can get an individual, the more adaptations that come along and the more that they can improve their health. But again, you want to balance out not too little exercise and not too intense of exercise as well. So finding that comfortable Goldilocks zone for the patient. Minimum 3 supervised sessions per week, because again, this person is dealing with physiological changes that most normal people aren't. And so exercise runs a higher risk of something happening. So some sort of, episode happening, especially if the intensity of this exercise is too great and the person cannot handle it, well then, you run the risk of maybe someone feeling dizzy or passing out or something along those lines. So always having supervision with a patient with a condition is optimal. If at minimum, 2 supervised sessions and 1 at-home sessions where they get lighter intensity of exercise on their own. So as we've talked about before, when you go from rest to exercise, it's best to include warm-up. This gets the body prepared for physical activity, and this is especially important in those with a disease or for older individuals. And so make sure that you include maybe some dynamic stretching, some things to warm up and increase the muscle temperature and increase the body temperature a little bit. And this is going to help the person with tolerance to that physical activity. And in addition to that, include a cool down. A lot of younger individuals, healthy individuals, this warm up and cool down, not saying it's not important, but you're running less risk with a healthier individual with not including a warm up and cool down. As individuals age and in those with certain diseases, it's very, very important that you transition them from rest to exercise and from exercise to rest. We talked about before, cardiac output will drop significantly after that first couple of minutes after working out. So you want to include the cool down to reduce the likelihood of dizziness, nauseousness, or even the person passing out. So if someone has mild COPD or well-controlled asthma, we're going to go by the FIT principle here as far as exercise prescription is concerned. So at least 3 to 5 days a week. The more active you can get them, the better. Intensity, it's debated. Again, you probably want to aid on the side of caution as far as physical activity intensity is concerned. But there are a lot of research studies out there that show that high intensity exercise could even help improve conditions of those with mild COPD. But again, I think just as with most individuals, start off small, start off with lower intensities, and as the person shows that they can handle it, then you bump it up little by little. 20 to 60 minutes per session, and the type of physical activity, walking, stationary cycling, low, moderate intensity aerobic exercise will be sufficient. And you also want to make sure that you include some resistance and flexibility training in there as well. If the condition is a little bit worse, so if those have moderate or severe COPD, you want to keep the intensity under 80%, and that means typically heart rate maximum or heart rate reserve. You want to keep it between that 60 to 80% on a 0 to 10 scale, nothing higher than a 5. So constantly making sure that you are checking in with the patient if they have this severe condition, and making sure that they can handle this intensity of exercise. So again, that frequency is going to be 3 to 5 days a week, but time may be adjusted. They're not going to be able to handle an hour of physical activity. So even if it's 10 minutes at a time, getting the person to move, getting the person to breathe in deeper and participate in physical activity is just key. And you want to keep the intensity, again, very, very light with these conditions. Walking, stationary cycling, low intensity activities at first, and then if the patient or the client shows improvement, well, then you can experiment with bumping up that intensity little by little. It's very important to include resistance training, especially of the core, because that's going to have positive impacts if we strengthen our core as far as breathing is concerned, especially exhaling. Also improving the strength of the muscles of the midsection. That's just going to help the person overall. And so you should try to include a couple sessions of that resistance training. 2 to 4 sets, 8 to 12 reps, and 2 to 3 minutes rest in between, making sure that the person can tolerate it. 48 hours between muscle groups, and include both multi and single joint exercises. So we also have another separate training therapy, and this is called respiratory muscle training. And so here you see a device which makes it harder for individuals to breathe out. And so it's called resistive breathing training. And so you may ask yourself, well, why would you want to, in those with COPD, include a therapy that makes it harder for them to breathe? And the real reason you're doing this is to build the strength of these respiratory muscles. So just as with weight training, you're picking this heavy load, this heavy resistance to try to lift against, right, this external load. This is the same thing for respiratory muscles. So if you make it harder for the individual to try to breathe out, well, then the strength of those respiratory muscles are going to increase. And so, if you do this 4 to 5 days a week, again, you're not making it so hard for the individual to breathe out air. You're just adding a little bit of resistance, so those respiratory muscles have to work harder. And again, the overall goal is just to get those respiratory muscles stronger. So by providing a little bit of resistance, it could go a long way as far as respiratory muscle health is concerned. And so be careful when you're working out with individuals on a bronchodilator. Again, just as any medication, it can have consequences as far as exercise training is concerned. And you always want to make sure that they have their bronchodilator with them during an exercise session. On their own, you can prescribe some pursed lip breathing, so inhaling deep through the nose and then breathing out with some resistance through the mouth. Again, this will help the individual build up the strength of that respiratory muscles. And also make sure during resistance training you're using proper technique and avoiding the Valsalva maneuver, avoiding increasing that pressure as you lift, because again, we have differences in compliance and differences in airway compression in those with COPD. So that Valsalva maneuver, inhaling deep and bracing your midsection, that could have negative consequences for those with COPD. So always, saying to the client, breathe in, breathe out, being cognizant of that breathing will be beneficial. Also, make sure that they're able to handle the intensity. Look at their heart rate. Ask them how their difficulty of breathing is during the physical activity. If you do have access to one of those clips that goes on the finger to measure saturation of oxygen during a graded exercise test, that would be beneficial as well. And just be cognizant of those with supplemental oxygen. They're not going to be able to handle a high intensity of physical activity, so considerations there. And then just on this last page here, this is just a figure, describing the components of a pulmonary rehabilitation program, which you can read on your own. All right, that's it. That concludes the lectures for the rest of the semester. So review the Block 4 lectures and get prepared for your fourth exam. Thank you guys so much, and we'll see you next time.